velum area. So understanding this is very, very important. And in the next 15-20 minutes, whatever it takes, I'll try to make you understand how soft palate actually collapses during sleep apnea, and you'll realize why we have really not been able to treat sleep apnea so far, because our whole understanding of the palate collapse is very primitive. Our whole understanding of the tonsil itself is very primitive. When we talk of, we all think as ENT surgeons that we know a lot about tonsils. Let's see how much we know about tonsils. So let's try to understand the palatal anatomy in great detail. So when we look at the soft palate from the front, we are looking at the tonsil, we are looking at the uvula, we are looking at the tongue. Now, is this the airway or the foodway? What we are looking at is not the airway. It's the way food is supposed to go inside. Is that correct? So I'll not talk of any scientific terms. I'll not talk of any, big jazzy names. I'll talk of common sense. We are looking at the foodway. This is the way food goes inside. Where does mouth is made by God to eat, not to breathe. Nose is made to breathe. Is that correct? Is there any rocket science in that? No. So where is the airway? Airway is actually at the back of the throat. When it gets blocked by sleep apnea, then the brain wakes up the patient, and that's the cycle. And that's sleep apnea. I'll just play it again. So the airway is at the back of the nose. This is the regular airway which passes through back of the soft palate, back of the tongue, and then into the lower airway. And when there is a block at that point, then the brain has to wake. Wow, very nice. Thank you very much. So technology finally has to work. So this is where is the obstruction happening, and then the brain has to wake up the patient. If the brain does not wake up the patient, what will happen? Patient will die. Simple. And that's obstructive sleep apnea. Now let's understand the structures. Back of the soft palate we know is the commonest area where the blockage happens. So what are the structures affecting the soft palate? These are the structures, you all know about it. Now I'll show you a drug-induced sleep endoscopy. When a person is snoring, we are trying to go and figure out what is happening inside. I think this is the most important video in the entire sleep apnea gamut. Okay, so if we look back, what structures we are dealing with? Where is the collapse happening? Do you have a pointer by any chance? Do you have a pointer, Chaitanya? Yeah. So if you look at this, this is the area which is collapsing. Now follow it. What is the area which is collapsing? Is it the tip of the uvula or the base of the uvula? Anyone? Correct. No rocket science. It's not the tip of the uvula, it's the base of the uvula. Correct? Now, how is the uvula moving? Anteriorly or posteriorly? It's moving posteriorly. Soft palate is moving posteriorly. There's no confusion about it. Now, where is the blockage happening? What is this other structure? Right, this is the tonsil. So, this is the lower pole of the tonsil, and this is the, which pole of the tonsil is this? I know many of you will be seeing this video for the first time, but it's common sense. We are looking at the back of the soft palate. Unless you actively think, see, what is the, which is this structure? Tonsil, correct? Uvula and tonsil. Now, where is, this is the lower pole and this is the, it has to be the upper pole, na? See, don't think that I'll talk of somebody American and Italian, and there's no need to take, I'm just talking of lower pole, upper pole of the tonsil. And what is the structure covering the upper pole of the tonsil here? Besides the uvula, what can come? Sorry? anterior pillar. We are looking the tonsils from the back. It has to be the posterior pillar, correct? That's what I said. We are typically, we are looking from the front. So we look at the anterior pillar. Now we are looking from the back because the airway is the back. We are following the airway. So it has to be the posterior pillar. What is posterior pillar made of? Palatopharyngeus. So now the anatomy is very clear. Now, during snoring, what movements are happening to the tonsils? Is it turning? Is it rotating? Is it getting lifted, or a combination of all those movements? A combination, correct? So is it adducting? Is it going medially? Is it rotating? The upper pole is coming more closer than the lower pole. Can you see that? And is it also going posteriorly? Unless all these three happen, the airway will not get blocked. So now we'll just try to understand, has this been explained on this earth so far? If we do not understand what is happening during snoring, how do we treat snoring? So we'll just put it into perspective. When we look at the tonsils, what happens? Now I'm looking from the front. So the tonsil is going superior, it is going turning, it is actually rotating. The superior pole is getting more medial than the lower pole because the attachment is here. So it's getting superior, it's going medial, and it's also going posterior. To look at that, you'll have to look at the structures from the other angle. So this is the movement of the structures happening. From this angle, it's also going posteriorly. And which structure is actually blocking it? Palatopharyngeus, right? Because it's pushing onto the palatopharyngeus behind. Now, the traditional classification of tonsils, grade 1, 2, 3, 4, all of you know. Anybody who doesn't know it? Nobody. So this is very, very well understood. Everybody knows about it. But unfortunately, this is not enough. Tonsil is a 3D structure, so it has got 3 axes. Unfortunately, are looking at only one of the dimensions of the tonsils. We are looking only at the tummy of the tonsil. Because we are looking from one perspective. Our perspective is not complete. We are looking from one direction, so we are looking at only one dimension of the tonsil. We are forgetting about the height of the tonsil and the width of the tonsil, the shoulders of the tonsil and the head of the tonsil. We are forgetting about them. That's the problem. We are only looking at the tummy of the tonsil, which is only one of the dimensions of the tonsil. We are forgetting about the width, which is the shoulder, and the height of the tonsil, which is the head. The other 2 dimensions are not. So if the width of the tonsil and the height of the tonsil increases, what happens? It pushes at the back, it pushes in the front. Front is the oral cavity, so there is no problem. But it also pushes at the back. And we saw that the bottleneck area was the base of the uvula and the palatopharyngeus, which is this area. We just saw it, right? If the width of the tonsil is more, it will press more on the palatopharyngeus. If the height of the tonsil is more, it will push more on the upper part of the palatopharyngeus and block it further. So when you remove the tonsil, you remove the blockage at the back like this. This was the bottleneck area, base of the uvula and palatopharyngeus, which was covering the upper pole of the tonsil. The moment you remove the tonsil, this is what you achieve. So not only you remove the tummy of the tonsil, you also remove the height and the width of the tonsil. Now tonsils are of 2 types, exophytic or big tonsils, which all of you have seen, right? But many a times you would have tonsils which do not look so big, but when you go inside, they are found actually buried tonsils or endophytic tonsils. So exophytic tonsils, it's very easy to understand how it blocks the airway. But how many of you would have seen a sleep endoscopy like this? With exophytic tonsils, how many of you have actually seen a tonsil like this? One hand. In a sleep endoscopy, only Sagar, obviously. You guys will see everything. I'm talking on most of the delegates. You hardly ever see such kind of a sleep endoscopy. It's not very common to have such big exophytic tonsils. then where is the problem? Our whole classification is wrong of tonsil. We have to look at more ways of, is not wrong, it's incomplete. Let me put it that way. More problem is because of the endophytic tonsils, which are inside the pillars. So when they block, when they go behind, they block at this place, and that's what we just saw in the sleep endoscopy. That was the place which actually causes problem. And the endoscopy will look like this. That's the tonsil, this is the upper pole, and the big upper pole, see the collapse. Always, always, always like that. Palatal collapse, this is the commonest thing. There will be different patterns, but this is the commonest. These are the structures. So, with the understanding of how the movement takes place and what is the role of tonsils, how does it go, let's now understand the muscles of the soft palate. So, there are 5 muscles in the soft palate. Musculus uvuli, which will pull up the soft palate in the midline. The levator palati, which will lift the soft palate. Levator palati, it will lift the soft palate. Tensor palati will tense the soft palate. Palatoglossus will pull the soft palate down and anterior. Palatopharyngeus will pull the soft palate down and posterior. Correct? Basic anatomy. Now, let's see the action of different muscles. The tensor palati is the most anterior of all the problems, of all the muscles. And this is tensing the palate so that the soft palate is having this movement. So, this is good for the airway or bad for the airway? Airway is here behind. So, when tensor palati is tensing the soft palate, it is good for the airway or bad for the, it's good for the airway, correct? So, because the collapse is happening here, if the airway, if this is tense, this is good for the airway. And this is the most anterior muscle. You will never ever have a collapse in that area unless the soft palate is so posteriorly placed, so vertical, that this area also creates problem. So, tensor palati by and large will never have effect on sleep apnea and snoring. I have okay. So, tensor palati, we have absolutely no business getting into tensor palati. And this is the muscle responsible for your velopharyngeal sufficiency, right? So, this we have no business anyways. Now, the other important muscle is levator palati. The job of this muscle is to lift the soft palate and bring it towards the posterior pharyngeal wall so that the palate can close, so that when I am speaking, my voice does not sound like hypernasal. If my levator palati is not working, my voice will become like this. When I drink water, the water will go into my nose. That's the job of tensor palati and levator palati. Levator palati, this is the area again which is responsible for your velopharyngeal sufficiency. And what we have seen, the blockage area in most of the cases is at the level of palatopharyngeus and not at the level of the levator palati. So again, there is no business getting into levator palati and tensor palati. And if you do not touch these two muscles, can you ever get velopharyngeal insufficiency? Because these are the only two muscles which are lifting and tensing the palate. So whatever you do down, unless you are, using cautery and creating a rope like fibrosis down, you can never ever create velopharyngeal insufficiency. Very easy. So most of the time these two muscles are not involved into obstructive sleep apnea. And the moment you do not touch them, you have absolutely no fear of getting into velopharyngeal insufficiency. Now, this is the anterior pillar of the tonsil, which is the palatoglossus, which is attaching the soft palate to the tongue. It's going to pull the soft palate down and anterior. So again, this is good for the airway or bad for the airway? It's good for the airway, correct? Because the airway is behind here. So again, this muscle is good for the airway. So it's our friend, it's not our enemy. It's only palatopharyngeus which pulls the soft palate behind and posteriorly and inferiorly. It's only this part. This is obviously an exaggeration so that you can understand it easy. Only this muscle, palatopharyngeus, is your enemy. And now let's look back at all the kind of palatal surgeries that you have read, seen, that you are going to see today. They are based on which muscle? Palatopharyngeus. So this is the reason. See, unless you understand anatomy and physiology first year, then the pathology, then the pharmacology, how you can go into surgery and medicine? So before you see Srinivas and Sagar doing good palatal surgeries, you understand that why they are acting on this muscle and they are not acting on all the other muscles. So whatever you do below these two muscles is fine. It will not give you velopharyngeal insufficiency, and therefore this is called the Lakshman Rekha. Srinivas very nicely calls it Lakshman Rekha. So why it is Lakshman Rekha? Because if you go above this point, then you will have a problem. If you are below this point, you will never have a problem, unless you are obviously not following surgical principles. If you are following surgical principles, there will be no problem. Now, how do you identify this point? When the person is actually awake, when you are examining in the OPD, say from tomorrow morning, every patient that you do a throat examination, ask him to say ah, or press the tongue and ask him to say E. The palate will go and touch the back. Wherever that point goes and touches the back, that is the point where levator palati is actually, right? So you'll have an idea of where is that point. Now when the person is relaxed, you cannot see that, and then when the person is relaxed under general anesthesia. So you have an idea of where that point is. If you see it on 100 patients from tomorrow morning, in next 1 week's time, you will have a fair idea of what is the safe area to operate on the soft palate. And let me tell you, 99 out of 100 times, that line will be just above the line joining anterior pillar to anterior pillar. Check it out from tomorrow morning. Now again, this is not described anywhere, but this is common experience. We should be writing papers. We are a little lazy. We are doing workshop but not writing papers. So that line, that point is just above the line joining anterior pillar to anterior pillar. That is the base of the uvula. So base of the uvula is the cause of snoring, and the levator palati is at least half a centimeter above that. Always, always. You check it out. So that's the, like we know how appendix can be removed without a problem and person can stay without. So that is the part where you can perform a zeta palatoplasty, expansion pharyngoplasty, modified UPPP, Fairbanks technique, whatever you want to do. That is the area that you can perform a surgery in, but you should not go high, otherwise you will get a problem. Now, different types of collapses. Now, this is an antero-posterior collapse. So this is a AP collapse, correct? Now, what is the structure involved here? So this is the base of the uvula, you all have seen. What is the structure just besides the base of the uvula? Palatopharyngeus, posterior pillar, there cannot be anything else anatomically. So AP collapse is caused by the base of the uvula and medial part of the palatopharyngeus. Correct? Palatopharyngeus is a fan-shaped muscle. So palatopharyngeus is not on the side, it comes till the midline. Right? It's a fan-shaped muscle. So medial part of this is causing AP collapse. Look at the lateral collapse. You follow this structure which is causing lateral collapse, and you will see that again it is the same structure. Let me just fast forward because we are running late. If you see it again, again the same structure. See this, just behind the tonsil. It is the same structure. It is again the posterior pillar, the lateral part of the posterior pillar, which is behind the tonsil, not the middle part. Lateral part of the palatopharyngeus again is responsible for your lateral collapse. And circular collapse is both in common, AP plus lateral, and a part also collapsing of the posterior pharyngeal wall is called circular collapse. So again, these are the same structure. Because it's a collapsible tube, sometimes it will collapse like this, sometimes it will collapse like this. Predominantly it will collapse in a certain way, but in different situations it can collapse depending on what is the pressure. I'll just show you this. So what kind of collapses you'll call it now? AP, lateral or circular? You'll call it circular, very nice. What kind of collapse you'll call it now? Lateral. And then the moment this, you'll call it AP. So this is what I want to make you understand, that there are classifications given by our friends. Nothing is complete. So you have to understand what structure, what anatomy, and then you will be able to deal with these structures, because just going by a classification, it's a dynamic thing. It's not a static thing. It's not a CT scan that you see and bony structure will remain constant. It's a dynamic collapse. So it's a dynamic thing. It's your eye, it's your understanding on the entire thing that will make you understand. So more important than this AP lateral, which is a type of collapse of the lower part of the soft palate, we have to understand that most of the soft palate luckily only have a lower part of the soft palate collapse. Most of them look like a funnel. That means the upper part is broad. The part constituted by the levator and the tensor, levator palati and tensor palati, is broad. There's no problem in that area, and that is the area of the soft palate that we require for function. Luckily, God has made it like that. More than 90% is like this, our funnel palates. Looking like a funnel? All we looked, everything is looking like a funnel? Looking like a funnel? Some palates, 5 to 10% look like a tunnel. Everything collapses, even the upper part collapses. They are vertical palates. If you look at this, right from top to bottom, everything is collapsing. So even if you operate on the lower part, upper part will still keep on collapsing, and that part is formed by the levator palati and the tensor palati. You cannot remove, you cannot resect, you cannot do anything on that part. So these are the cases which you have to actually try CPAP. Do not operate on them, because you are not going to get good result. If you try to do advancement palatoplasty, Srinivas, I think we'll have a talk on palate, or Sagar. So there are techniques for them which are not very widely accepted, but so these are the palates you have to exclude. And let me not get into the techniques of the surgery, where enough surgery is lined up. Salpingopharyngeal fold, again, now this is one structure. We have come out with a classification of this. We identified this structure in 2010-11, and then I talked to Srinivas, Sagar, Krishnan, Vijay Krishnan, everybody. We all started finding that yes, this structure is responsible in a great number of cases. Around 20 to 30% of the cases we have salpingopharyngeal fold hypertrophy, and you can understand if there's a problem at this level, whatever surgery you do on the soft palate, base, tongue, epiglottis and nose is going to fail completely, because the problem is not there. So just 2 days back, I got the mail from Indian journal, our own Indian journal. We have come out with a classification system, grade 0, 1, 2. Our paper has been accepted. So this is the first time in the world that classification and identification of salpingopharyngeal fold as an important cause of obstructive sleep apnea has been described, and we understand that we have to deal with this structure. Otherwise, whatever you do on the soft palate is not going to work. So with this, let me stop here because of want of time. I have already exceeded my time. I'm sorry for that. So with the understanding of the anatomy and the functioning of the soft palate, what is the next program? Sorry? Yeah, so come Sagar. So now that we have understood how does the soft palate cause sleep apnea, what do you do when a patient of sleep apnea actually comes to your clinic? You want this or you want hand mic? Yeah. So you need to understand what you would do when a patient of sleep apnea steps into your clinic. What are the questions you will ask? Because you all have limited time, and patients will present in a varied manner. So you have to know what basic minimum questions you want to ask, what investigations you will do, how will you proceed. So Dr. Vidyasagar will deal with workup for OSA in a sleep clinic.
Good morning. Good morning. Am I audible? Check. Yeah. Good morning to everyone. At the outset, I would like to thank Dr. G.V.S. Rao, sir, and Dr. Chaitanya for inviting me for this wonderful CME on OSA. I think Vikas has given a beautiful lecture for all of us to understand the anatomy, especially of the palate, how it contributes for the blockade that is happening in the patients with obstructive sleep apnea. Now, my talk is going to be very simple, easy way for you to understand. I'll try to be as quick as possible. My job is to make you understand what you should be doing when a patient whom you think is possibly having snoring and sleep apnea walks into your clinic. I'll just tell how I would do it, and then from there Dr. Deendayal sir and Dr. Srinivas will take further, and then we'll talk about the surgical point and all subsequently. Thus, because we're saying the prevalence of this syndrome is humongous. If you go through any of the studies, it says it's ranging anywhere between 7 to 10%. If we take our population to be 132 crores, approximately 10 to 13 crore people are suffering with obstructive sleep apnea. And exactly what Vikas was saying, whose specialty is it? Since he has beautifully put forth that we are the persons who are dealing with the obstruction that is happening in the upper airway, we should be taking the lead role and we should evaluate it. And that is in fact the main reason for this particular CME that Dr. Rao has organized it, so that we can take this specialty further and take it into our command and work from there. So now the first and foremost question is, do these patients come to your clinic walking with a label that they are sleep apneic? Like let's say a patient with thyroid goiter, they know that they obviously have a swelling and they come into you. But do you think the same thing happens with the patients with obstructive sleep apnea? Not very often. Sometimes yes, if you are especially dealing with the specialized practice of sleep apnea, yes, you may get a referral practice. But many times it is a spouse that brings you the patient, the bed partner, and he or she is the one who is going to tell the problem that in fact the patient is having problem at night. And sometimes it is you who is seeing the patient for some other problem, let it be a sinusitis or let it be a chronic suppurative otitis media. If you see the patient having symptoms or signs which is correlating with snoring and obstructive sleep apnea, you have to put the leading questions. You have to get the information from the patient, and then you have to diagnose this problem. Because if you don't diagnose the problem, being as an ENT, then someone else is going to grab this, and they are just going to give the CPAP. But to understand and ask the questions properly, you need to know the pathophysiology. What happens during the night? At the sleep onset, because of the reduced dilator muscle activity, the airway collapses. And because it collapses, the patient goes in for apnea. And because of the apnea, there is hypoxia and hypercapnia. And this stimulates the brain and makes the brain to wake up, and the tone gets opened up, and the airway gets opened up, and the patient breathes normally. And this cycle goes on and on and on throughout the night. This arousal is called as microarousals, and because of this microarousals that happens throughout the night, the patient is going to have both the nighttime symptoms as well as the daytime symptoms. You need to know all the symptoms and signs so that you can ask the leading questions when the patient comes to your clinic. Like, is the patient having snoring? These questions, especially the nighttime symptoms, you may have to ask them from the bed partners or the spouse. So, did they witness any apneic spell? Or do they have restless sleep? Do they get multiple times? Do they have the habit of going to the restroom at night? And because they have microarousals multiple times in the night, they have the daytime symptoms. They are not full of pep. They feel drowsy in the morning. They have fatigability because sleep is an active phenomenon. They may have poor memory, decreased concentration, and they fall asleep during the work, and more importantly, even while driving. And you not only have to know about the symptoms, but you also need to know the complications of obstructive sleep apnea if they don't get treated properly at the proper time. So what are the complications? If you don't treat the obstructive sleep apnea at the proper time, 60 to 70% of them may end up having hypertension. 20% may have ischemic heart disease, and 10 to 15% may have right heart failure. Similar is the data for all the other symptoms. 60% gastroesophageal reflux disease, 20% erectile dysfunction is contributed by obstructive sleep apnea, and motor vehicle accidents, more commonly noted nowadays, is because of obstructive sleep apnea. So you need to know not just the signs and symptoms of obstructive sleep apnea, but you also need to know what are the complications that can happen if you don't treat the patient properly. So now, with this idea, you should start asking the patient the leading questions, and before you directly see the patient, we in our clinic have this set of questionnaires called as stop bank questionnaire, Epworth Sleepiness Scale questionnaire, and the Berlin Sleep questionnaires. These questionnaires are given to the patient while they are waiting in my clinic. As soon as the patient walks in, I'm just going to tell how a patient coming with sleep apnea is treated or managed by me in my clinic. All right. So as soon as a patient comes in, one of my assistants takes the history, and if the patient falls into the sleep apnea category, then these patients are given this questionnaires. So one of the most important questionnaire is the stop bank questionnaire, Berlin Sleep questionnaire, and the Epworth Sleepiness Scale. So are these questionnaires going to tell us that the patient is having sleep apnea? Not necessarily. These questions are just asking them whether the patient has tendency to fall asleep while they are watching a TV or sitting quietly after lunch. These are the questions meant to tell whether the patient is having excessive sleepiness or not. It does not say whether the patient is actually having sleep apnea or not. But still, this is important. On the contrary, the stop bank questionnaire, it's one of the key questionnaire that we use, has all these parameters, and in this stop bank questionnaire, if the point is more than 5 to 8, then the patient has high probability that the patient may have obstructive sleep apnea. But these are just questionnaires. These are not 100% diagnostic, all right? So now, after the patient has filled out these questionnaires, then my assistant again records all these things, which are very key and paramount in evaluation of snoring and sleep apnea. So number one, weight and height. Most importantly, these two combined together will give BMI. The importance of BMI is higher the BMI, the chances that the patient may have obstructive sleep apnea is higher. Not just that, if the patient is having high BMI, let's say the BMI is more than 35 or 40, then if you are a surgeon, if I am a surgeon, and if I'm going to think about doing a dynamic obstruction in that particular patient, I will think twice before I put the knife in, because these are poor candidates for surgery. So this is one important vital information that all my patients gets recorded in. Next, history of hypertension, diabetes, hypothyroidism. Hypothyroidism, so key important history. Are they hypothyroid or not? If not, get the patient evaluated for hypothyroid, because these patients may have symptoms and signs very similar to sleep apnea, and if you just treat these patients, most of the patients may get rid of their symptoms that is almost similar to sleep apnea. We would get a thorough cardiac, pulmonary, and endocrine history. We would also measure the neck circumference and the waist circumference, and a complete ENT examination, including the Friedman staging, would be done for all these patients. Now, does this examination constitute that the patient is having obstructive sleep apnea or not? No. The one and only tool that can tell us for sure that the patient in fact is having sleep apnea or not is the sleep study. The sleep study is of three main types, even though we consider it as of 4 levels. The commonest one that we use is a level 3 study, which is a screening study. A level 2 study is a study which is a complete full sleep study that is done at home, and level 1 study is this one that is done in lab. So this is the level 3 study, which is constituting only the respiratory channels, and the level 1 study will include all the EEG monitoring as well, which will tell for sure whether the patient is sleeping or not. Now, these are all the monitors that were attached to the patient for whom who is undergoing either a level 1 or level 2 study. So when this patient undergoes a sleep study, this is how the recording or tracing happens during the sleep. This one epoch, we call it, is for 30 seconds, and you can see how the patient is sleeping or not. This is a stage 2 sleep, and you can see these are the snoring episodes that is happening, and this is the wave patterns that the patient is having a normal breathing here. Now, in a patient with apnea, this is how it will look. You can see that there is no breathing at the level of the nose or at the level of the thorax. But after an apneic spell, you can see that there is desaturation that is happening, and because of this desaturation, the patient wakes up and immediately the saturation goes up, and also the airway gets restored, and this is called as arousal. So now, with the complete study that is done for almost 6 to 7 hour study, we get a report like this. In this report, the first and foremost thing that we need to look in is whether the patient actually slept or not. That is given by the sleep efficiency. It's right here. And you also need to see whether the patient has gone through all the stages of sleep or not, whether the patient has gone through the stage 1, 2, 3 and REM sleep or not. And then you have to look into the most important parameter of AHI or apnea hypopnea index. If the apnea hypopnea index is more than 5, then it is considered to be positive in adults. If the scores are between 5 to 15, it is considered as mild sleep apnea. 15 to 30 is considered as moderate sleep apnea, and more than 30 is considered as severe sleep apnea. And not just AHI is important. The other important parameters that we would look in is the saturations. What is the lowest saturation that the patient is having? And what is the mean longest desaturation that the patient is having? These two categories, these two parameters are important not just to assess the severity of the desaturation and sleep apnea, but also if you're going to do a DISE, a drug-induced sleep endoscopy, you would need these two parameters, and you should inform your anesthetist that tell your anesthetist that this patient routinely goes in for that desaturation, let it be if it is 78 or 80, that is this natural routine desaturation that is happening. So while you are performing a DISE, if the saturation goes down to 78, then the anesthetist need not panic. If it is going below the level of lowest oxygen saturation that the patient is having, then only he should be trying to think about giving oxygen supplement or something that Srinivas will be telling shortly. The other things that you should see is whether these apnea and hypopnea are happening in what kind of body position. Is it happening in the supine? Is it happening in the lateral position? Or is it happening in the prone position? Most of the times, if it is happening in the supine, and as soon as the patient turns back into the lateral position, if the apnea and hypopnea disappears, and if it is happening for more than 50% of the time, then we call it as POSAS, positional induced obstructive sleep apnea. So all these parameters are taken into the consideration, and then you make a diagnosis whether the patient is in fact having apnea, obstructive sleep apnea or not, and then only you are going to go for a management. The traditional management by a sleep physician would be, without even evaluation of the airway, they would directly give a CPAP. Up to 30 to 40% may accept it and they may be doing good, but 60% of them may not do good, and that is because of either poor CPAP tolerance or improper evaluation of the patient. This is one such patient wherein a CPAP was given to a patient without even evaluation, and you can notice that this patient is having a significant epiglottic collapse. See what happens here? It is like a trap door that is closing. And if this patient is given a CPAP, what is it going to do? It is going to push the air further, and it is going to collapse the epiglottis even further, and the patient will not tolerate CPAP. Yes or no? So that's why you need to have a good evaluation in your clinic before ever the patient is even advised of a CPAP. So the first and foremost evaluation that is done in your clinic is going to be with your flexible fibro-optic examination. We call it as flexible Nasopharyngolaryngoscopy. So what are you going to get from this? As Vikas was saying, there are two types of obstructions. One is a structural obstruction or a static obstruction. The other one is a dynamic obstruction, that is like a neuromuscular incoordination that happens during sleep, and that is called as dynamic obstruction. And this obstruction can happen in multiple levels, not necessarily at the level of the palate. So what it means, it can occur at the level of the nose, It can happen at the level of the velum or the velopharynx. It can happen at the level of the oropharynx. It can happen at the level of the tongue base, or most importantly, even larynx. So all these things can be assessed by your flexible nasopharyngolaryngoscopy. So what does the flexible nasopharyngolaryngoscopy give detail in your clinic? It definitely tells whether the patient is having a static obstruction or not. Like the patient is having a gross deviated septum, a huge tubular hypertrophy, or big multiple polyps, or is there a nasopharyngeal mass, or not necessarily like adenoid. It could be something else. It could be a tubal tonsil like this, or sometimes even a static obstruction in the form of torn wall cyst or some other lesion. Sometimes even nasopharyngeal malignancies and JNAs have been given CPAP. And this is another gentleman who had used a CPAP. And he was given CPAP without even examining his oropharynx. Just putting the tongue depressed, you can see a huge mass there. And this patient was given a CPAP and he was considered as a CPAP failure. And this patient indeed had a parapharyngeal mass, parapharyngeal tumor, and just by removal of that, the patient did well. Similarly, there is another child diagnosed with obstructive sleep apnea. Just by putting your flexible nasopharyngoscope, you can see a lingual thyroid there, and that was the cause for obstructive sleep apnea. And similar is the patient here with an adult patient, again a lingual thyroid, and this is a child again having a retropharyngeal mass that was actually a schwannoma, and that patient had snoring and sleep apnea, and that patient was also mistreated as sleep apnea. So now I've talked about the static obstructions that you can see at the level of the in your clinic, but what other thing that can happen is the dynamic obstruction. The dynamic obstruction happens only at the night during the sleep. Is there a way that you can identify them in your clinic? Possibly yes, if the obstruction is at the level of the palate. So we do what is called as Muller's maneuver. We ask the patient to sniff in while we are putting the endoscope in, and we do this Muller's maneuver and we observe what is happening at the level of the palate and the tongue base. At the level of the palate, it has been found that it corresponds to at least 2/3 correlation between what the examination, the finding that you notice in Muller's maneuver and then DISE, which means 2/3 of the time you will be accurate at the level of the palate. But when you come to the tongue base level, it is corresponding only to 1/3 level, 1/3, which means only 1/3 of the time the finding that you identify with Muller's maneuver correlates actually with your DISE finding. So that's why it is so important to have a dynamic assessment for these patients when there is no static obstruction. And this dynamic obstruction can be done in two forms, either in the form of drug-induced sleep endoscopy, which Srinivas is going to brief us all about, and the other one is dynamic MR. There is a dynamic MRI wherein a patient is given a full meal, and preferably at night when the MR gantry is free, he schedules a patient, and as soon as he takes a full meal, he goes for a sleep, right? And when he goes in for sleep, then that is the time we do this assessment. And in this assessment also, we can see whether the patient is having any collapsibility of the airway, and if so, is it happening at single level or is it happening at multiple levels? And we also do it in multiple sections, both in sagittal, coronal and axial, and The advantage of this investigation is that we can actually measure the cross-sectional area in all the dimensions so that we can have a pre-op dimensional assessment, and if you are doing a post-op dynamic MR, you can compare how much of improvement you have given for that particular patient. And obviously the other dynamic evaluation is the drug-induced sleep endoscopy that I think Srinivas is going to talk about in detail. But after the dynamic obstruction, if you see there is a dynamic obstruction, and then only you should give the patient a trial of CPAP. And if the patient has only a dynamic obstruction and if he fails CPAP trial, then only I would consider patient for the surgery. And most of the workup is almost going to be similar to all of your surgical workup. Plus, you have to be very vigilant about your thyroid profile, getting a good cardiac fitness, and a CT scan OSA protocol that I will show you in my second talk. What is that and how I do it, I'll talk about it in the subsequent talk. So with this, I'm going to conclude my talk. I think if you have any questions, I'll be happy to answer, because Srinivas is going to talk all in detail about drug-induced sleep endoscopy. I think I'll leave that investigation or evaluation for him. And if anyone has any questions, you can feel free to ask.
HDMI cable. That's fine. I think. Good morning. Good morning to everyone. At the outset, I would like to congratulate Dr. Rao's ENT Hospital and Hyderabad ENT Foundation, and especially Dr. Chaitanya, for organizing this particular meet on snoring and obstructive sleep apnea. And special thanks to my dear friend, Dr. GVS Rao, for asking me to be a part of this program. Before I start my talk, I know I've been given 15 minutes. Can I extend by another 3-4 minutes if it's okay? I just want to know how many people are actively involved in managing snoring and obstructive sleep apnea here. Can you just raise your hands up once so that I get to know what I have to talk? You don't come into that. Only one. Okay. So before I start my talk, I would like you to know, in the year 1979, when I had joined ENT, we never had this particular word called obstructive sleep apnea. We did not know anything about it. It was not documented. It is only in the past 30 years that obstructive sleep apnea word has been coined, and it has been recognized as a disease entity. And I also want you to quickly understand, how did these 30 years go? It was only after they found out about polysomnography that they started to see that there are phases of apnea, hypopneas. And what they started to look at is, who is the best person to interpret this? It was similar to an EEG. So that is where a neurophysician came into the picture, and he started evaluating the polysomnography much better. So all these cases which were then diagnosed as obstructive sleep apnea started going to neurophysicians. Then came in with the invention of a PAP machine for a positive airway pressure. And where was this used? It was used in acute medical care. And acute medical care, where you are dealing with the lungs, who came into the picture? The pulmonologist came into the picture, and he started understanding a PAP machine much better. And that is where the cases for treatment started going towards a pulmonologist, diagnosed by a neurophysician, treated by a pulmonologist. Sadly, the ENT surgeon did not come into the picture here, but if you really look at the pathophysiology that has been beautifully put forward, the pathophysiology is in the upper airway, right from the tip of the nose to the larynx. Upper airway is the domain of an ENT surgeon. And the ENT surgeon should be aware of evaluating snoring and obstructive sleep apnea. And I think the evaluation has been beautifully put forward by Dr. Sagar, and Dr. Vikas has beautifully given you the anatomy. What I just want you to understand is, why should I waste my time knowing about this disease? Please remember, 1 in 4 snore. So with the group that is sitting over here, you can calculate. Number 2, 1 in 5 have obstructive sleep apnea, out of which about 70% are from mild to moderate, and they don't go for treatment, and it is only the 30% that is severe, they start going for treatment. So the load of work for obstructive sleep apnea is humongous, and you need to remember that you are the primary physician, and that is why I want to quickly run through what is our role in the management. If you look at the classification of 1997, there are 84 sleep disorders. So don't ever think that you're a sleep disorder specialist. Don't ever think. There are 84 sleep disorders, and this is the domain of a neurophysician. And they consist of dysomnias, parasomnias, sleep disorder associated with medical and psychiatric disorders, and proposed sleep disorders. And if you look at the symptomatology, there are roughly, you can classify them into insomnia, excessive sleepiness, circadian sleep-wake rhythm disorders, and parasomnias. You need to keep in mind, you are only worried about excessive daytime sleepiness. This excessive daytime sleepiness comes into your purview. All other things don't come into your purview, except sometimes associated parasomnias that could be there. So when you're looking at the whole continuum of sleep disorder breathing, it starts with normal, then the patient goes into snoring, a little more obstruction, they go into upper airway or upper airway resistance syndrome, a little more obstruction, they go into obstructive sleep apnea, and the worst form is Pickwickian syndrome. So as the obstructions increase with symptomatology, the continuum goes from a normal to a Pickwickian syndrome. So they can present with only one symptom called snoring, nothing else. But a snoring could be something like a serious medical problem like obstructive sleep apnea. So unless you evaluate this patient, you cannot diagnose. When you talk about obstructive sleep apnea syndrome, you should know that they should have associated symptoms along with a sleep study telling that there are apneas or hypopneas of more than 5. This is one condition we need to keep in mind, upper airway resistance syndrome, wherein a very difficult condition to diagnose, a very difficult condition. The presentation would be typically there, and remember these are all lean patients. So their only statement is unrefreshed sleep, generalized symptoms of like irritable bowel, having myalgias, and having not that well good feeling in the morning. But this is one thing you need to keep in mind before you start treating them. A word that as an ENT surgeon we should keep in mind 4 factors. Whenever there is an incompetent tone of the palatal, tongue, or pharyngeal muscles, there is an upper airway collapse. That is what is called as dynamic obstruction. A space occupying masses like a large tonsil, large adenoid, a big muscular tongue base that is falling at the back is what is called as static obstruction. That means that cannot be dynamic but is all the time present. A third thing you need to keep in mind is the excessive length of the uvula and the palate in cases, and this is where these patients have snoring and obstructive sleep apnea. And very interestingly, you know that nasal obstruction can also cause snoring and obstructive sleep apnea. How does it cause? Oral breathing gets into a Bernoulli phenomena, that is air traveling at a velocity, causes negative pressure at the surroundings and collapsibility of the tube. So that's when you're breathing, the upper airway starts collapsing. So don't overlook even nasal obstruction. So where do we come in as ENT surgeons? You know, pulmonologists are giving PAP medicine. We should know also how to treat PAP. But we come into the picture, if you look at this statistics, average, this main thing is put forward that only 50% of people really use a PAP machine. 50% don't use. This is another presentation that talks about only 50% using. The third one you see long-term compliance, 54%. So you come into the picture because you have to show these people an alternative way of management. PAP therapy is not the answer for every case. Like Dr. Sagar had put forward, if there is an epiglottic collapse, you put a PAP machine, the patient will choke. The only answer for these patients is surgery. So you need to understand that you are a very important person in the management of snoring and obstructive sleep apnea, and don't think that the other person is better. So in fact, another point you need to keep in mind is even if they are using PAP medicine, PAP therapy, only 68% people use it through the whole night. Rest of them hardly use it. They only use it for a part time. So surgery is here to stay. It is not here to go. And please again keep in mind that surgery, as time passes, it is going to evolve. That now we are talking of we'll give a PAP trial and then surgery. There will come a time where we will talk about surgery, and if that is giving good result, good. Later on support it with a PAP. That is the word that is going to come in the future because of the anatomical defects that we can beautifully clear off. So this whole thing has been talked about beautifully by Dr. Sagar, all the evaluation part of it. What I want you to remember as an otolaryngologist is that we have 4 levels of obstruction. That is a level 1, level 2, level 3 and level 4. So as a surgeon, if you have to treat this patient, most of the time, when I'm talking 75% of the time, it is multi-level obstruction. It is only 25% of the time, it is a single level obstruction. So you should be able to identify where the obstruction is and how you are going to plan out your surgery. So for that a little help, you have what is called as a Friedman tongue position. You can definitely get into and get this from the books. You have the tonsil size that has already been talked about. You have a Moore classification that talks about how big the tongue base is for you to evaluate. And another thing called as Friedman staging. Staging will roughly give you an idea that maybe if it is at stage 4 and where the BMI is above 40, you should not operate. And a nice point here I'd like to mention, which Dr. Vikas was stressing about, is if you look at a stage 1, where the success rate is between 80 and 88%, look at the tonsil size 3 and 4. The larger tonsil you are seeing orally, the success rate is better. Those tonsils that are buried in size, where you classify them as tonsil size 1 and 2, are the ones that are troublemakers. So you got to keep that point in mind. So whenever you are looking at a surgical treatment as a ENT surgeon, keep in mind we have to give a result almost equal to that of a CPAP. Almost equal to that. That is where we have to aim at. And there are a whole list of surgical indications, but I would like to stress about anatomical sites of obstruction. If they are present, we need to correct them. If we correct them, the airway will definitely improve. And there are a lot of contraindications, but we need to understand most important thing is unrealistic expectations. We only talk of improvement, we don't talk of cure. So a standard way of evaluation has to be done, and we have to know that when we say our operation is a success, we have to talk about the AHI, whether it has reduced, oxygen saturation improvement, symptomatology improvement is what? That is what is called as quality of life improvement. So I'll quickly go through. You need to know that as an ENT surgeon, depending on the level of obstruction, you have a nasal, palatal surgery, tongue-based surgery, you have a maxillary mandibular advancement, and even tracheostomy. Tracheostomy is the only surgery that gives 100% cure. If a patient asks, I want 100% cure from surgery, the answer is tracheostomy. Most of them will not accept for it. So that is where you talk in terms of improvement rather than cure. So nasal surgery, you have to remember that whenever you improve the airway, it will definitely improve the patient's symptomatology and at the same time help in a CPAP use. Depending on where the pathology is, you can correct. And if you look at the evaluation part, you will see that all surgeries that are being done will not to that extent affect the snoring and AHI. It will affect only minimally, but it will support your supportive treatment for palate or tongue base. Similarly, there are a lot of minimally invasive procedures. This surgery is obsolete. You have uvulectomy, you have a capso, which is a much simpler procedure. All this will be talked about. Palatal injection, snoroplasty. The somnoplasty is there, where you stiffen the palate. All this is for mild obstructive sleep apnea and snoring. You have palatal implants also that are there, internationally available. there's a lot of literature that talks about a good improvement. This is what I'm trying to tell you, that if somebody puts forward a statement that surgery is not that effective, it's a wrong statement. Surgery has been proved to be effective provided you select the patient correctly, and what surgery to be done you need to know. So there are different procedures from UPPP to Zeta, which will be discussed, advancement palatoplasty, expansion sphincter, you have lateral. All these again show that the results are good. Similarly, there are minimally invasive tongue-based surgeries which are present, suspension, lingual tonsillectomies, and we have hypopharyngeal surgeries where you do a midline glossectomy, genioglossus advancement, hyoid suspension, there are hyomandibular suspension and hyoid expansion. Even we talked today about transoral robotic tongue-based reduction. Again, you see the results are good. This is what I'm trying to put forward. Maxillary mandibular advancement is a phase 2 surgery where other surgeries fail. Here, you see the success rate is 90% and more. Some people have almost near 100% success rate. Tracheostomy, even though it gives you 100%, there are specific indications where you have to tell the patient that that is the treatment of choice. So tracheostomy again has shown that the 5-year mortality rate compared to non-tracheostomized has been much, much better. So tracheostomy definitely improves the lifespan. You need to know when the BMI is above 40 that these patients have to be sent for bariatric surgery. There are reports telling that it is good. Again, pediatric obstructive sleep apnea. There is a talk on it, but here again, we otolaryngologists, along with the facial-maxillary surgeons, we have a big role to play. There are again literature telling that the results are good for adenotonsillectomy and other allied procedures. Multi-level surgeries, that at a one single stage you can operate at 2 or 3 levels. There's a lot of literature talking in terms of the success rate being excellent and the complication rates being minimal. So, taking all these points into consideration, as an ENT surgeon, we need to know that we got to be the primary person. Number 2, that surgery is here to stay, not to go. And number 3, we should know which treatment is appropriate for which patient and when are surgical treatments appropriate. You should know that. Thank you. Thank you very much. Thank you.
I request Dr. Sudarshan to moderate this session. Now onwards, I told you in between I'll interrupt and I'll talk like this for a minute. Okay? Thank you. Thank you, Ashok and ETV team to be with us. Thank you. I'll see you again. Please don't leave us without taking lunch. Please. Thank you. Thank you, Sudarshan. Please moderate this session.
Thank you, sir. I request Dr. Srinivas Kishore to talk on DISE from consent to reporting.
Sir, may I? Good morning, everybody. Am I all right or am I too loud? All right. Okay. At the outset, I would like to thank Dr. GVS, Dr. Chaitanya to have called me here. This is the first time I'm coming here, even though I've gone past this place many times. So it's a fantastic place. I should really congratulate you all for this. So, without further delay, let me just go and talk about what I'm here to talk, which is drug-induced sleep endoscopy. Now, Dr. Vikas and Dr. Vidyasagar and Dr. Dindyal spoke a little bit about this. Now, I'm going to go a little bit in detail. Drug-induced sleep endoscopy for us surgeons is where we actually become physicians or interventional, like a gastroenterologist or something, wherein we give a lot of attention to what we are actually seeing, all right? Because a lot of it, what we do will depend upon how we see it, how we interpret it. As you all know, obstructive sleep apnea is a condition caused by partial or complete obstruction happening at multiple levels, and all of us know that. And what is the gold standard therapy? It's CPAP. And all of us agree to that the gold standard therapy is CPAP. But the problem with CPAP is, number one, compliance, number two, adherence. All right? And I hope you all understand that there's a difference between both of them. Poor adherence also can lead to poor compliance and vice versa. Now, little bit going back into literature and seeing a few literature related topics on CPAP adherence. Now, this is a paper that's come out of Stanford, okay? Stanford is the Tirupati or Mecca for obstructive sleep apnea because everything was coined there. This is by Cleet Kushida, who did a study which is a 6-month randomized double-blind 2-arm sham-controlled multi-center trial of 1,500 patients, okay? So this is a significant number. Now what did they infer? They inferred that the compliance rate among people who use CPAP is 39%. Now you've given a CPAP to a patient and he's taken it, has bought it. You've not even made sure that he's using it. And you've actually gone back and checked whether the person is using it. Only 39% are using it. So that's pretty bad. And if you look at this table that's come out of Brian Rottenberg, who actually said that from the years 1996 to 2011, there are many kinds of nasal masks, we call them nasal interfaces, that have come in. There are different kinds of technologies in CPAP that have come in, but none of them have changed the adherence. From 1996, this is the, sir.
3,300 doctors are watching across the world now, this program. Thank you. Thanks a lot.
Thank you, sir. No problem, sir. So, from 1996 to 2011, the adherence level has just not changed. It is 50% then. It is actually getting lower now. 2010-11, this is of course 7 years old data. But what is this telling us? This is basically telling us that no matter what kind of adaptations and technologies that come out to you, the adherence still remains the same. So the problem is not with the technology, the problem is with the human being. So that needs to be individualized and treatment needs to be individualized. Adherence also is because of problems like this. This is an adult patient with adenoids. This is an 18-year-old for whom CPAP and BiPAP were given because the AHI was not going down. And like the speakers before me said, nobody bothered to put a scope down to see what is going on before they gave in a CPAP. And of course, there are dynamic obstructions like this, which actually also cause impaired CPAP adherence. So, when you have patients like this, all you have to do is go to your closest Walden or Crossword and buy a book. Cure your sleep apnea without CPAP. It's easy, right? All you have to do is buy that book. But have you all checked it out? It's available. Maybe it's on Amazon. Probably you'll get that. But unfortunately, it's out of stock and it's been out of stock for quite some time. So we probably don't have access to that. So when you have a problem like a patient who is not adherent to CPAP, a doctor like you, a physician like you, is like this particular gentleman. You have multiple options. Now what are you going to do? There are multiple options. You are in front of these doors, which door to knock? Because you have tried the CPAP, which is the gold standard therapy. You found out that the gold standard therapy is not working for these patients. So now you are here and you have all these doors to open. Now how do you know which is the right door for you? Right? You don't want to keep opening each door and see, okay, this is going to work or this is going to work. Evaluation, dear colleagues, is the key. It's always evaluation which tells you which door will open up the best treatment option for your patient. So, how should you evaluate? And why should you evaluate? Why you should evaluate? Because our predecessors did not evaluate, and they did this surgery called uvulopalatopharyngoplasty for every single patient. And what happened to the results? Your success rate was about 40%. So we know that you don't have one single procedure for this. So every CPAP failure should not be exposed to a surgery called uvulopalatopharyngoplasty. You will have to evaluate to improve your success rate. So, which are all the doors that I was talking about? Is it surgery? Is it positional therapy? Is it oral appliance? Or is it a combination of therapy? So how do you want to select in all this array of treatment options that you have? Well, there are a whole list of different treatment modalities if you open a textbook. There are awake and there are sleep. Amongst all these sort of modalities that are available, the easiest to perform is Muller's maneuver, which Dr. Sagar spoke about. And I will not show you the video of how it is done. All I will tell you is that, so do we all do it? As practicing sleep apnea surgeons, do we do Muller's? Yes, we do. And why do we do it? We do it because the patient also needs to understand at what level what is happening for you. In the outpatient department, supposing you find a swelling in the vallecula like I showed you before, supposing you find an adenoid there, it's a static obstruction. So the patient himself already understands that there is an obstruction right there in the outpatient and he understands the seriousness of the problem. But there are lots of disadvantages. Disadvantage is it's not accurate or useful just by itself. So if you want to say that I would want to select my surgical patients just based on Muller's maneuver, you're wrong. And that's what the data is telling us. So then what do? Then there is this huge statement that's come out there looking at you saying evaluation in sleep changes treatment choices in 40 to 75% of your patients. And that's not what I am saying. This is what literature is saying. Look at the DISE papers published just in PubMed. If you look at 1990 to 1999, 8 papers, 2000 to 2009, 28 papers, 2010 to 2015, 102 papers, and from 2015 till date, already 72 papers have been published on DISE. So that means if there is so much work that is being done, so you'll have to take it by its face value that it is here to stay. Now, what is sleep endoscopy all about? Now, since you can't go into people's bedrooms carrying your Pentax or your Olympus or your stores, whatever your company is, and you can't go into people's bedrooms and start doing endoscopies in their rooms and their bedrooms, it's obviously severe deprivation of their privacy. What is the next best thing that you can do? You can actually sedate a patient with a particular drug. Yes, you heard it right, sedate, and obviously all of you would say sedate, and how are you even close to sleep? So I'll talk about that. So the idea for you as somebody who wants to understand the behavior of the upper airway during a person's sleep, because this is obstructive sleep apnea and not obstructive awake apnea, you want to understand the behavior of the upper airway during a person's sleep. So how do you do that? By sedating the patient. Now, when does drug-induced sleep endoscopy come? You have done the polysomnography, you have offered a CPAP, for whatever reason the person can't use the CPAP or doesn't want to use the CPAP, that is when DISE comes in as a treatment selection in order to select what is the best treatment. Now, this does not come here, or this is not an option for this. You understood? A lot of people come and say, why not just do a DISE? Why should we do a sleep study? Because you are talking about two different things. Sleep endoscopy will give you the anatomy, will give you the structure causing the obstruction, the pattern causing the obstruction, the severity of the obstruction. But sleep endoscopy gives you the need for treatment, the urgency for treatment, and the impact of this particular condition on various cardiorespiratory and neurological conditions. Now, remember I said sedated or drugs? So, people actually thought like us, and what they did was they took a patient, they did a sleep study on the patient with propofol, and they did sleep study on the patient without the drug. Alright? And what did they find? This is the patient's PSG on spontaneous sleep, AHI 16, same patient, PSG with propofol, same respiratory parameters. So what is that telling you? It's telling you that this is sort of giving you, the drug-induced sleep is sort of giving you a very similar kind of sleep as natural sleep is. So the respiratory parameters, when you look at spontaneous sleep and drug-induced sleep, are the same. Are you with me? You understand? And that is why there are only 3 drugs that are selected to perform drug-induced sleep endoscopy: propofol, midazolam, and dexmedetomidine. So, what are the indications? The indications are very few. 1, you have a CPAP failed patient. You want to identify why he's failed CPAP and what you can do. 2, you want to also identify why he failed CPAP, whether you want to give another option to him by taking care of that obstruction and giving him another CPAP trial, or you want to do a surgery for this patient and control his sleep apnea, or you have done a surgery and you failed and you want to know why you failed, or you want to give a mandibular repositioning appliance or an MRA. In these conditions, DISE is used. Are there any contraindications? Well, if you take precautions, which I'm going to talk to you a little bit about, we can, there are certain limited contraindications, but by and large, this is just not an absolute contraindication like I've mentioned here, it's a relative contraindication. So, what are the prerequisites? So this is not a simple VLE or a DNE. So this is not a patient who is going to just come to your clinic and say, come lie down and I'm going to do a sleep endoscopy. It's not going to happen. Here, you are actually dealing with a syndromic patient who has carbon dioxide retention in the body, and for whatever reason you want to put him to sleep using a drug that may depress the respiratory center. So when you are doing such a thing, it's prudent that you get a pre-anesthesia checkup done. You need to do it in a endoscopy suite, or you need to do it in an OT. Please, always under the presence of a anesthetist. Don't do it by yourself. You must have a place where you can administer oxygen. Now I will talk a little bit about these two. These two become very important. Target controlled infusion. What is TCI? Because we are giving a drug and we don't want to be over sedating your patient, so you punch in the details of the patient's weight and BMI and all that. The computer actually creates the dose ideal for that patient and gives it, so that you are not over sedating your patient. Similarly, bispectral index scoring, which is a number that the computer gives you, which is a sum of all the data that's coming from the frontal cortex leads. So the technique, NPO, you have to give an anticholinergic half an hour before. Make sure that you don't, the anesthetic doesn't trickle into the throat, and you have to have a flexible scope. Earlier when we were talking almost 3-4 years ago, there are people who actually used to send us drug-induced sleep endoscopies using rigid scopes. Please don't do that. Now, this is the list of the drugs: propofol, midazolam, and dexmedetomidine. You can, you can understand the whole thing. I'll be happy to share it if you want to, but I want to talk about two things here. One is cardiovascular profile and respiratory profile for these three drugs. Now, propofol, all of us know that there is no OT without propofol. So this is a great induction agent, and lot of studies have been done with this. The anesthetists who do drug-induced sleep endoscopies love propofol because of quick onset of action, and it actually gives you N2 sleep, and that has been proven. So adult human beings, all of us have N2 sleep. Midazolam is now slowly losing flavor. Dexmedetomidine is the new kid on the block. Every anesthetist likes dexmedetomidine. Why? This is one single drug, absolutely has no respiratory side effects. So you, as a person who's treating a OSA, and also somebody who's an anesthetist who's giving sedation, would love it. But dexmedetomidine has effects on the heart. So if you have a patient who's got cardiac issues, or is on digoxin for whatever reason, or is having beta blockers, dexmedetomidine may not be the drug of choice. Now, you can deliver these drugs either as a bolus, as a pump infusion, or target control infusion. And I'll be happy to share this slide with you all if you want to know. Let's get to the main things. Now, this is a paper which actually said using DISE, you can actually titrate your CPAP. How were we titrating it before? We were doing sleep study half the night. And how many of you know about split night studies? Raise of hands. Right. So split night studies are what we were using before. What you can do now, and this is published, is that you can actually do your DISE, and as you're doing DISE, you can keep increasing the CPAP pressure, and then see at what pressure it's opening up and at what level your AHIs are getting normal. And that is where DISE has reached now. Now, just to give you a little comparison between propofol versus dexmedetomidine before we go further, and I'll just come to the conclusion. Patients with propofol group had significantly increased likelihood of demonstrating tongue base collapse. And why is that? That's because propofol has another trick up his sleeve, and that is decreased genioglossus tone. It has been seen that people for whom you have done a DISE using propofol, there's a 10% decrease in genioglossus tone. So it becomes very important that you use a BIS when you do, and I will talk to you the differences between that later. Now, here is again a similar thing, basically showing how dexmedetomidine scores over propofol. Again, same thing, propofol over combination with dexmedetomidine. Now, what is the setup? You have a BIS monitor, you have the BIS leads, and this is how you do that's your BIS monitor. The patient is sleeping. Obviously, the sound is come down because he's not breathing that well. And this is how you do it, and this is what you see. So as the patient is breathing in, complete obstruction there, there's no air going in. Let me know when I have to stop, please. I don't have I'm lost. So it's important if you can actually see and measure the snoring. Now, once you've done the DISE, there is no universal scoring system. So you use what is called as the vote classification. Now, what is the vote classification? Velum, oropharynx, tongue base, and epiglottis, because it has been found that this is the commonest sites of obstruction when you do a DISE. So, and you come out with this particular chart, which from the beginning I think our colleagues have been showing, and you score whether it's a 1 or a 2. 1 means partial obstruction, 2 means complete obstruction. So that tomorrow we do a DISE, so you do a DISE, and we need to talk to each other. We speak in this language. So there are other classifications, but this is the most accepted classification. Now, when you see a DISE, and if you put all the data that's out there, and you do a 2-level classification, and you found out where are all the obstructions happening, 91% of obstructions happening through DISE are in the soft palate, whereas 58% are in tongue base. You know where I'm arriving at. If you have an obstruction which is 58%, which is a significant number, so you can't say that I will just do a palate and ignore 60%. If you use a 4-level classification, that is soft palate, tonsil, tongue base, and epiglottis. This is from all the DISE data that's ever been published. Again, 84% is soft palate, 32% is tonsil, 51% is tongue base, and you will be surprised that 34.3% is epiglottis. And you know, single factor that is responsible for CPAP failure is epiglottis. So straight away, when you see an epiglottis, you already know this is a CPAP failure, and that is 34%. Now, what about the phenotypes in the soft palate itself? 46% is concentric, 44% is AP, and 9% is only lateral. So, if you have a concentric obstruction, again, which is a bad prognostic factor for most of the surgeries. So you need to be very specific with what you're doing. What about obstructions at the level of soft palate when you compare complete and incomplete? So most of the obstructions at the palate are complete. So that's not surprising. But what is surprising is about 56% obstruction at the hypopharynx, that's including tongue base and epiglottis, is a complete obstruction. Yeah. 4 minutes? Yeah. So here are certain examples of DISE. So here is a obstruction at lateral. Here is a lateral obstruction. Lateral 2. All right. And for wanting to go beyond and see. There is an obstruction which is a primary epiglottic collapse happening on lateral direction. Now, I will jump all this and come to a particular scenario. Now, what is this? This is a nasopharyngeal airway. What you're planning to do is to splint open the palate and the oropharynx. So how do you know even before that by doing this it may work? So if you were to put a nasopharyngeal airway which would actually mimic your palatal surgery and your oropharyngeal surgery and actually try and see if the rest of the airway is collapsing, and the collapse is not because of Bernoulli's phenomena but is only happening because of the obstruction itself. So if you do this, see now beyond the nasopharyngeal airway the rest of the palate is not collapsing. So you know in this particular patient that your palatal surgery will work. However, if you have this patient, in spite of the nasopharyngeal airway being there just at the level of the epiglottis, still collapsing. So you know that your procedure obviously will not be that successful. So that way your simple nasopharyngeal airway will guide you how to go about with your patients. One more thing. Most of our patients are mouth breathers, right? So when you have a mouth breathing patient, you know that the tongue, when you're opening the mouth, the tongue falls back. And how do you know that the palate that is collapsing is not because of the tongue base and it's only because of the palate? That case is what we do, a DISE from the mouth. Look at this patient, the same patient. The mouth has opened his mouth, going down. How the tongue is folded inside the mouth, and that's the little uvula that's stuck between the tongue. So that the air is still going because it's vibrating and the tongue is not causing the obstruction. Right? So that is how it's important that when you do your DISE, it's just not enough that you just do a nasal procedure, nasal endoscopy. You need to go through the mouth as well. Now, one more. What is advanced DISE? Now, our colleagues in the pulmonology fraternity would basically say that, well, you are actually doing drug-induced sleep endoscopy. You are inducing drugs. That's not natural sleep. What we do is you connect the drug-induced, the infusion machine. You do a full level 1 PSG, connect all the leads, and perform drug-induced sleep endoscopy. Right? So when you do that, you are actually trying to be as physiologically sound as possible. So this is the PSG fully connected. That's the laptop which is actually recording the EEG leads, and this is what you would get. What you would get. Right? This is a hypopnea. Oh. Now, one more thing. So, Dr. Vikas showed a beautiful video that said that the same patient, he showed anterior posterior, lateral and circumferential collapse. Now this is the paper that actually says all that. It is shown that at start, what starts off as a anteroposterior at 8 minutes becomes lateral and at 16 minutes becomes circumferential. Now how does that happen? That is because every human being is not stuck in one stage of sleep. A person goes through different phases of sleep, and that is why you need to do your DISE for a minimum period of 16 minutes. And also, please understand this slide. If you have to have a DISE, which and your BIS finding where BIS number is showing more than 82, that means that the patient is awake. And if your BIS is showing 82 and you're seeing collapse at the level, at whatever level, you're probably not assessing the patient properly. If your BIS is less than 62 and you're seeing certain particular anatomy there, you're probably overscoring your patient because it's at N3 and most adult human beings don't sleep at N3. Here, let me just skip. Now, this is an example of the same. Now, BIS at 80, right? 82, airway is open. Now, same thing, BIS at 70. The pharynx is going, obstructing at all levels, right? So that is the importance of BIS. That how do you know how deep you're going? What stage of sleep you're really assessing? And you can actually see the palate collapsing, then you will see the epiglottis going on in all kinds of directions, and now it's looking like a lateral epiglottic collapse. So, DISE is basically, oh God, they cut me off? This okay? No, I've seen this happen to me before. So, DISE is useful to titrate your PAPs. DISE is useful for surgery. DISE is useful for appliance, positional therapy, and assess sleep-mint failures. So this is a single modality that gives you so many different ways of evaluating your patients and doing what is best. Disadvantages, it's time consuming, it's costly, basically based on what you can decide whether it's costly or no. Over sedation can reduce muscle tone, what I was talking about, especially genioglossus, but you can overcome that by using BIS. And these two things can be solved by using BIS. Saturations, be very careful to do it only in the OT or an endoscopy suite. Saliva aspiration, you can counter by giving glycopyrrolate. Laryngospasm, you can avoid by anesthetizing. Regurgitation and aspiration is possible, theoretically, but it's never happened. We have done about 500, 600 DISEs till date. So, DISE is a valid addition to polysomnography. The anatomical structures that involved in sound generation obstruction can be identified individually, and there are various studies that shows that DISE improves treatment outcomes as well. So, on this platform, I would say that DISE, you can say that the current gold standard in optimizing obstructive sleep apnea syndrome selection for OSA. I could definitely say that. Thank you so much for your patience here.
Thank you, Srinivas.
Sorry for exceeding, sir.
No.
Before conclusion by the moderator will be here. I want to tell something else than the snoring and sleep apnea. Dr. Rao's ENT started 23 years back only with the motto of serving the world. Here, one of my brother, Dr. Sudarshan Reddy, I love him. Anybody whoever want to do good service to the nation, good service to the, there is a world called DISE world, but our Pradhan Mantri Modi, he changed the name to they are great people. The great people. We have to help the great people on the earth. And so many kind people are here to help the great people. And with a kind heart, Dr. Sudarshan Reddy started a foundation called Sumant Foundation. It is started on June 2nd, 2017. I am getting, the director Dr. Chaitanya Rao is giving some recommendation from Dr. Rao's ENT hospitals. We started this hospital 3 years back. I don't have any expenditure. If you know this pant is 30 years old, you will get shocked. This cotton pant purchased in Chennai, 30 years old. My shirt is 30 years old. In that, I want to do something to my brother Sudarshan Reddy. Every month, I kept from my remuneration 10,000 rupees. This Sumant Foundation was started 14 months back. It is 1.4 lakhs is in this cover. And I am donating this 1.4 lakhs to the Sumant Foundation. I am handing over, requesting the directors, Dr. Sri Rao and Dr. Chaitanya Rao to come here. Because I told you, I am a senior worker here. I am coming and operating, teaching and going from here. The small people, they are, I don't know how they are feeling. In front of his teacher, Dr. Ramayan Garu here, Dr. Dindal Garu here, my good friends, Dr. Siddhi Reddy is here. And I request Dr. Sri Rao and Dr. Chaitanya Rao to come and hand over this cover to Dr. Sudarshan Reddy Garu. Sorry for interruption.
It's a great thing.
Come, please. This contains 1.4 lakhs. Please. This is for the Sumant Foundation. Please. Please, please. And I am very happy to say, we adopted 3 schools around these hospitals, and it may be surprise to you, every month Dr. Rao's ENT hospital is paying salary to a teacher of the one government school, and we are supplying slate pencils to the shoes to